Good morning. I would like to start my presentation thanking Nina Gorban and Bislev for their kind invitation to participate in this important uro-oncology meeting. My topic is a brief review on the WHO classification of the tumors of the urinary tract, which I have divided in two parts. This is the part one, mostly dedicated to urothelium, and then the second part, mostly dedicated to squamous and glandular neoplasms. If we review the outline of the new WHO classification blue book, and we take a look on the outline, this is basically quite similar to the outline of the previous edition of 2016. From a practice point of view, I will present some alterations on the classification of non-invasive urothelial neoplasm that is related to precursor lesions, including urothelial dysplasia and urothelial hyperplasia. Then we will review a brief on urothelial tumors grading, and then we will deal a bit on invasive urothelial carcinoma, mostly to terminology alterations and changes in this area of variant histology. Then we will complete a few words on genomic advances incorporated in WHO, and we'll end with some notes on PD-L1 assessment by pathologists. In this slide, what we have is an historical perspective of classification and grading of urothelial carcinoma of the bladder. You see here from 1973 to 2022. This table includes the classification of urothelial lesions based on the WHO classification and related to non-invasive or invasive urothelial neoplasms. Concerning non-invasive urothelial neoplasms, the main changes are related to the precursor lesions. As you see in the left side of the screen, we had in the past two lesions in this category, urothelial dysplasia and urothelial proliferation of uncertain malignant potential. That was previously called papillary urothelial hyperplasia. These two entities disappeared on the 5th edition. And concerning urothelial dysplasia, we must recognize that this is a greatly debated term. It is uncommon. Is more frequently seen in samples of patients on follow-up for low-grade urothelial carcinoma or follow-up for urothelial carcinoma in situ. There is a lack of precise histologic criteria, and there is poor inter-observer reproducibility concerning this term of urothelial dysplasia. And there is also a lack of robust clinical outcome data. In the WHO 22 book, urothelial dysplasia is defined as a preneoplastic lesion with cytological atypia, not definitive for the diagnosis of urothelial carcinoma in situ. It is recognized, however, that the term dysplasia is clinically needed in sometimes. My point of practice is to summarize urothelial dysplasia in the fact that this is not a unique term anymore in the WHO Blue Book. It is potentially relevant to identify atypical urothelial biopsies not associated to inflammatory background. The finding of dysplasia could explain positive results of molecular testing in cases with no tumor on cystoscopy. And my suggestion is, until a better term is available, still use the term urothelial dysplasia to describe these clinically relevant situations. The second precursor is the so-called papillary urothelial hyperplasia. This is a morphological lesion that can be recognized and could potentially be the earliest morphological surrogate of low-grade papillary neoplasia. This, as you see here, this is a picture of papillary urothelial hyperplasia. You see this undulating aspect is seen as a minor alteration with reddish due to this congestion of the vessels behind or below the urothelium. And this, as mentioned, may be seen on cystoscopy. From a biological point of view, it is known that these lesions have chromosome 9 deletions and fibrillary growth factor receptor 3 mutations. 2/3 of the patients had history of prior or concurrent urothelial neoplasia. It is considered as an early manifestation of low-grade papillary urothelial neoplasia. The 5 years actual risk of developing urothelial neoplasia on follow-up of these patients is about 40%. It has also been reported in a de novo setting, means unrelated to a clinical history of urothelial neoplasia. In those cases, we do not have information regarding its meaning, its significance in the clinic. Concerning the WHO, it is not a unique term anymore. It is recognized that it's potentially relevant. My view is that it could be an early molecular or useful in early molecular diagnosis of recurrence when you using this type of tests in urine, or it could be also recognized in developing early therapies to avoid recurrences of these tumors. But this might be something for the future. My view is to report this entity when present as a papillary urothelial hyperplasia until a better term is defined. Here you see on the left side an example of papillary urothelial hyperplasia, and on the right side CIS with papillary architecture. So why is that? This is important for you to know that papillary hyperplasia maybe is an early neoplasm, but is not related to carcinoma in situ. Okay? It is not related. Carcinoma in situ has high-grade features and maybe occasionally have this papillary architecture, but those are lacking in papillary hyperplasia. Here, I would like to share with you a recent publication we have conducted on this papillary urothelial hyperplasia. It is related to molecular analysis of TERT promoter mutation and fibrillary growth factor receptor mutations. Our findings support papillary urothelial hyperplasia as a precursor role of papillary urothelial neoplasia. And that is because we have seen that about 44% of the cases, they have third promoter mutations, and about 23% have these fibroblast growth factor receptor 3 mutations. So as you see here in the right side panel, you see that the proximity of the third promoter mutation for papillary urothelial hyperplasia and low-grade non-invasive urothelial carcinoma. And concerning the fibroblast growth factor receptor, this is present in about half of compared to low-grade non-invasive papillary urothelial carcinoma. Concerning grading of non-invasive urothelial carcinoma, there is no big change. So basically, we have the same classification and grading, the PANLAB. We have the low-grade and high-grade urothelial carcinoma. Just to remind you that PANLAB is less aggressive, as far as we know, than low-grade carcinoma. But less aggressive doesn't mean it is not aggressive. So as you see here, we have in this meta-analysis, we have 35 recurrence, 30.7 stage progression, and 1.2 associated related mortality with PANLAB. We compare with low grade, as you see here, 49% recurrence, 9% stage progression, about 4% tumor-related mortality. So it is quite interesting to use this entity. High grade, in the same line, it has a high recurrent rate of near 60% of the cases, stage progression from 27 to 60% also, and survival about between 74 to 90% survival. Means that if properly managed, this patient can have a good oncological outcome. How pathologists in Europe practice grading of urothelial carcinoma? We have investigated that issue, and we observed that most of GU pathologists use both for grading the 1973 and the 2004 low-grade versus high-grade. So basically it's 50-50. PANLAB in that particular study was rarely used in practice, and it was an attempt in 2016 of consensus for PANLAB that had no consensus. So there is no way to agree between two different pathologies using the term of PANLAB. But something is new that is coming is the proposal by the ASAP, the International Society of Urological Pathologies, of a hybrid three-tiered grading system, which would include the low-grade category of the WHO in 2004 and split the high-grade category into grade 2 and grade 3. We will follow this to see what happened. The current WHO classification has recognized that the low versus high grade grading is highly reproducible, and it provides clinically relevant prognostic and management information. As a novelties, they have included a cutoff to include a category as a high grade. This cutoff is the presence of high grade feature in more or equal to 5% of the tumor. In addition to that, they also have made a proposal to report low grade cases with less than 5% high grade component, thus recommending to report those cases as a low grade tumor with less than 5% high grade component. And why is that? That is because because this particular study conducted a few years ago by the group of John Hopkins, and in this particular group showed that the presence of this lower component of less than 5% high-grade component was not related to cancer mortality or stage progression. But they observed that cases of low grade with a small percentage, less than 5% of high-grade component, behaved better when treated by BCG. That was not significant in this study, but because of that, they pushed to add this novelty to the WHO, as you see here, and with the hope that this low-grade patient with less than 5% or equal to 5% high-grade component might be treated with BCG and then become cured or free of disease better. Another novelty is concerning inverted growth. There is a recommendation by the WHO to include the descriptor of inverted in any tumor with prominent inverted growth. This will help urologists to understand changes related to what they have seen at the moment of the cystoscopy. Concerning invasive carcinoma, there is no big changes other than terminology related to the so-called variant histology. Now, they should be called as histologic subtypes. And an attempt to provide a percentage of the subtype should be included in cases that are associated to conventional urothelial carcinoma. For those cases showing squamous, glandular, trophoblastic or differentiation, they, or even Mullerian differentiation, they suggest to separate these as a group, as a subtype, called urothelial carcinoma with divergent differentiation. Concerning specific changes, they are not. Basically, the morphology is the same, but they are, they have excluded large nested from the nested, and they have put together microcystic and tubular, which is of probably very limited relevance. But importantly, to increase our knowledge on the variant histology or subtypes is important because, as demonstrated by Warwick a few years ago, molecularly these morphologic variants or subtypes are molecularly heterogeneous. That is important in terms of understanding and developing future therapies. Concerning the genomic advances incorporated in the WHO, I have selected this image, this scheme from Robertson. It's a publication on Cell. This is called second TCGA molecular taxonomy classification. As you see here, they separate as the three luminal categories, one basal and one neuronal, not exactly the same, but similar to what we include as a neuroendocrine carcinomas. So importantly, they have also provided insights, as you see here, on immunohistochemistry to define these big subtypes, luminal or basal. And also provide some targets that are available in which these entities are enriched. For instance, luminal papillary is enriched in fibrillary growth factor receptor 3, and then potentially could be treated using these inhibitors. No? But also these luminal infiltrated might be treated with anti-PD-L1 immunocheckpoint inhibitors because it's enriched in PD-L1 expression, and the same for basal squamous that can be also treated with PD-L1 inhibitors or chemotherapy. As a novelty, also they have included this the so-called consensus molecular classification of muscle-invasive bladder carcinoma. You see, again, it's basically the classification by Robertson with a new category which is called stroma-rich, which is considered basically a poorly understood classification. But this is not finished because there are coming new classification and molecular proposals. For instance, in 2020, Robertson made this proposal for molecular classification that can be applied to T1 tumors, and we have also make a proposal of a molecular classification in 3 categories, that is luminal, basal, and double negative, that can be also applied, and it correlates quite well with all the immunocheckpoint inhibitors, with variants, with all these therapy issues. But what is also very important to us is the use of immunohistochemistry to provide in an easy way this basal and luminal classification in the pathology report. We have reviewed this issue and make the proposal to include together during a period of time the classic conventional histology related grade 1 or low grade, PANLAM, whatever, add to this classification by immunohistochemistry the luminal, basal, or neuronal classification, that can be very easy, and this should provide good information in terms of therapeutic approach of this patient, and mainly will provide urologists and oncologists with data to get familiar with this molecular classification or taxonomy, and favor in the future use or not in clinical practice this classification. The last part of the presentation is related to the PD-L1 assessment by immunohistochemistry. This has been very complex and still is with certain complexity related to this. In general, what we have is 5 different antibodies. We have 5 different algorithms. So in some of these algorithms use the evaluation of tumor cells and immunocells, like is this case by the 22C3, which provide this combined positive score with a cutoff of 10%. Then we have this 28.8 related to nivolumab. It is also quantified tumor cells in a percentage of less or more than 1%. Again, durvalumab uses this SP263, which is used tumor cells or immunocells up to more or less than 25%. Atezolizumab use this SP142 that only evaluates immunocells in a percentage or with a cutoff of 5%. And avelumab use again same, but tumor cells only, and this is a cutoff of 5%. In this study shows that the concordance of most of these algorithms is quite good, in particular to SP263, 28.8, 22C3. But the one who is out of this concordance is the SP142. So it's quite different, as you see here. Here is the 142. This is one image, same case. stain with 22C3 and sp263. They are basically, if you evaluate, tumor cells are clearly positive in both of them, and even some immunocells that are infiltrating. And just to remind you that PD-L1 expression is also being investigated in variant histology or subtypes, and it can be applied, this therapy can be applied to urothelial tumors with this category, with this morphology, and with similar results as the conventional urothelial carcinoma. So, to the end, WHO 2022 mostly refines previous concepts with minor modifications in both infiltrating and papillary neoplasms. Urothelial dysplasia is not considered as a unique term by the 2022 WHO, but its clinical value is recognized. Urothelial papillary hyperplasia is not considered a unique term by the WHO, but it is biological significance as early low-grade non-neoplastic invasive carcinoma is recognized. The presence of minor high-grade component in a low-grade non-invasive carcinoma should be reported. The WHO 22 addressed the potential clinical value of the molecular taxonomy of bladder cancer. Reported data suggests that several assays, DECU 22C3, 28.8, or the Ventana SP263 could be used interchangeable in detecting the PD-L1 status. Thank you very much. I'm ready to take any question.
Thank you very much. У кого-нибудь вопросы есть?
Да, мы переведем.
Okay. Questions.
We ask questions on Russian and translate.
Скажите, как я поняла, в новой классификации уже рекомендуют только high-grade, low-grade уротериальные карциномы. Применяют ли до сих пор классификацию 1973 года, ну, grade 1, grade 2, grade 3, или, в принципе, уже можно ее не использовать?
As we understand, now WHO recognized high-grade and low-grade carcinoma should be used classification 1973, G1, G3, G2, and G3 still.
Okay. Concerning grading, the current WHO classification and grading issue recognized, as in the past, a system based in 2 or 3 different categories. We have a long lump, and then we have low-grade carcinoma and high-grade carcinoma. Okay, that is the reality. And that works, okay? We know that it works. So the only question that is coming, and there are actually no novelty, because the cutoff of 5% to define high-grade lesions is in the pathology books. It's a classic one. We used it for several years. But it is true that this is the first time the WHO has incorporated this cutoff issue in the book. Okay, but what is happening, or what happened and is still happening over the last 20 years, is that still the previous grade 1, 2, and 3 classification of 1973 still is in use in many places around the world. And that is not because the pathologists want to do that. It's because many urologists around the world are still using, and they're happy with the use of this 3-tier category, okay? So these two opinions, 50-50 around the world, well, there is something needed to be done, okay? So what happened is that an important group of urologists, they have put together 3,000, 4,000 cases, so many cases, from different institutions. And they have compared both classifications. And they said, yes, conclusion, both classifications are good. But if we fuse some aspects of the two of them, we get better capacity of being predictive or predictor of progression, recurrence, and so on. That question is being discussed by many of us, and is still discussing, and will be very much discussed over the next year, because it's true. It seems like melting both classifications probably will be better. But why is that? Why is that? I don't know if I have 5 minutes to explain. If I have these 5 minutes to explain, is history. What happened in 1998 when we discussed by the first time and decide that a new classification, the pan-LAM, low grade and high grade, was needed, that was because the feeling by the clinicians, the urologists, is that not enough number of patients were properly treated using BCG. But nowadays, the paradigm is changing because we have new drugs and new problems. Now we don't care about recurrence. Important issue, but we cannot solve. But we can treat patients and we can identify patients with great probability of progression. And then we need a different approach. So what we need for the next few years is to have a clear cut of high-grade tumors, very high-grade tumors, because those will be treated using novel drugs, not BCG anymore, okay? So that's the paradigm changing that drives somehow our practice. Okay, so this is more or less I don't know if this explains what the question.
Спасибо за ответ.
Не вспомню все с самого начала.
Ну, кратко резюме.
Классификация pan-LAM G1 и G2, и G2 pan-LAM high grade, low grade, она работает, мы можем ее использовать, но тем не менее, если мы будем использовать трехступенчатую классификацию, урологи во всем мире, они до сих пор используют, они привыкли к этой классификации. И если мы будем ее использовать, возможно, мы им поможем как-то лучше лечить пациентов в каких-то моментах. Но, например, когда вот G2, когда мы как раз есть вот эти средние группы, когда мы не можем понять там low grade, high grade, и вот как раз G2 здесь может дать понять урологам, в какую сторону мы мыслим. То есть это может быть low grade G2, но все-таки как бы дать понять, что мы уходим уже в сторону более высокого грейда. Ну и парадигмы меняются, поэтому классификации будут эти изменяться. Но пока я так поняла, что мы, в общем-то, в параллели рекомендовано использовать две классификации, как мы использовали их раньше.
Thank you, Antonio. Еще будут вопросы? Thank you. That's all for questions.